of difficult airway. There is no emergency more acute than the one. There is no emergency more. There is no emergency more acute than the one which threatens oxygenation, because lack of oxygen not only stops the machine but wrecks the machinery. Brain can withstand hypoxia for up to 3 minutes. After that, brain starts damaging itself. And after 10 minutes, the damage is irreversible and beyond recovery. According to confidential inquiry of perioperative death study in US, 1 of 3 deaths caused solely by anesthesia resulted from failure to intubate the trachea. In UK, 41% of maternal deaths from anesthesia caused by difficulties with tracheal intubation. In 1991, from a closed-claim study in US, the airway trauma was associated with difficult intubation in 42% of the claims against anesthesiologists regarding medical litigation.
Problem hocche Mike?
Though the profile of anesthesia liability changed over decades, but still now the difficult airway related problems are among top rankers of the cases against medical litigation. The incidence of difficult intubation in literature is about 0.05 to 18%. The intubation is comparatively easy in most, difficult in some, but impossible in certain individuals. Airway management is really easy, except when it isn't. The assessment of the airway is a clinical examination, and the prediction of a difficult intubation is likely to remain a decision based on clinical judgment. And this clinical judgment is based on the expertise of the anesthesiologist and the resources available. Joseph Clover, Ralph Waters, Arthur Goodall, Alfred Kirsten, and Sir Evan Maggill all have contributed immensely for today's managing of airway safely. Let's check the airway anatomy. This is a schematic diagram. This box shows the nasal cavity, this one the oral cavity, both in the posteriorly ends in pharynx. Pharynx continues as larynx, and larynx continues as trachea. This is the sagittal section of a cadaver. This is nasal cavity, this is oral cavity. Behind pharynx, pharynx forms larynx, and larynx continues as trachea. This is the MRI picture. So what is difficult airway? Difficult airway is a clinical scenario in which an unassisted anesthesiologist finds it difficult to mask ventilate or to intubate or both. Difficult mask ventilation is a scenario in which an unassisted anesthesiologist, for an unassisted anesthesiologist, it is not possible to maintain saturation above 90% on 100% of oxygen in positive pressure mask ventilation. Difficult laryngoscopy is a situation where for the anesthesiologist it is not possible to visualize vocal cords. And a difficult intubation is a clinical condition when for anesthesiologist more than 3 attempts is needed or more than 10 minutes is consumed to intubate the trachea. For proper management of the airway, we need proper planning, and this planning starts in pre-anesthetic checkup clinics. And this PSC starts with, as usual, history taking. If the patient has any history regarding any history of radiotherapy, any history of recent onset of hoarseness of voice, any history regarding thyroid swelling, he or she may be a candidate for difficult airway. If the patient has a history of difficult intubations or ventilation earlier, in all probability, again he or she will present with difficult airway management case. But the reverse is not true. If previously he or she has a easy intubation, maybe with time, with increasing age or new pathology, he may present as difficult airway case. If there is any history of surgery of the airway, like surgery of the vocal cords or oncosurgery of the floor of the mouth, there is a high probability the patient will be a case of difficult airway. So the pre-anesthetic assessment of the airway is very important. In the pre-anesthetic assessment, we try to plan out our we want to chalk out our plan of anesthesia by predicting the difficult airway. The patient maybe can ventilate, can't intubate type of patient. We should not go from can't ventilate, can't intubate scenario, is dangerous. For planning of airway, we take the help of the mnemonic lemon, where L stands for look externally, E, evaluate the 3-3-2 rules, M, Mallampati scale, O stands for airway obstruction, and N for neck mobility. Now check out each slices of this lemon more in detail. Look externally. Look for any atypical facial features, obesity, facial hair, protruding tooth, tongue, etc. Then evaluate the 3-3-2 rules. Mouth opening should be at least 3 finger breadth. The distance from tip of the chin to hyoid should be at least 3 finger breadths. The distance between hyoid to thyroid cartilage should be at least 2 finger breadths. Mallampati score, we check this Mallampati score by till the patient widely opening the mouth. The Mallampati score 1 is usually easy to intubate. Score 4 is very difficult to intubate. Then any obstructions of the airway makes the case very difficult to intubate, like laryngeal trauma, foreign body obstruction, edematous tissues, burns, or any growth in the airway makes it very difficult. Neck mobility also very important. Flexions and extensions of the cervical vertebra is prior requirement of any easy intubation. Under no circumstances should the head or neck of the trauma patient be manipulated. So again, lemon, look externally. This is buck tooth, very difficult candidate for intubation. This is obesity with facial hair, very difficult candidate. This is the case of burn patient in our hospital. You can see this is the mouth opening under muscle relaxation and also the neck contracture. This patient is a old case of commando with deficiency of mandible here, a difficult candidate for laryngoscopy. Now evaluate the 3-3-2 rules. These are the two patients we have given anesthesia in our hospital. They are not posing for the photographs. This is their maximum mouth opening. This is after a road traffic accident. They have fixed the mandible, and this patient has congenital problem of temporomandibular joint. Now let's check the Mallampati score in detail. This is the class 1. Here we can see the anterior posterior pillar of tonsil, uvula, hard and soft palates. This is class 2. Only anterior pillars and part of the uvula is visible. This class 1 and class 2 patients are usually relatively easy to intubate. This is class 3. Here only the hard and soft palate is visible. This is moderately difficult to intubate. This is class 4. Only hard palate is visible. This is very difficult candidate for intubation. Sometimes the intubation becomes almost impossible. This is a growth in the floor of the mouth. This is also very difficult patient for intubation. Neck mobility is also a very important consideration. Sometimes the foreign body will be good enough for appreciation. Sometimes it may not be that visible. There may be a burn contracture that decreases the mobility of neck, or it can be any individual who may be suffering from a rheumatoid arthritis or osteoarthritis or even diabetes with restricted neck mobility. So we should check in every individual the neck mobility. We usually tend to forget this, but it is very important. There are some unique features of obstetric airway to make it to be difficult, like swelling of the larynx, nasal passages and tongue due to progesterone. This patient usually desaturates rapidly due to decreased functional residual capacity or increased oxygen consumption. There are increased chance of aspirations. Large engorged breast prevents proper laryngoscopy. Left lateral tilt hinders sleeping position. Over-enthusiastic required pressure also hinders laryngoscopy. Most obstetric anesthesia is rendered by juniors or in emergency situation, when the patient is suffering from excessive hypertension or in a case of spinal anesthesia failure. In case of obese patients or sleep apnea patients, they are also very difficult to maintain proper ventilation and oxygenation. These are cases of very difficult to ventilate. They usually desaturate rapidly. There is a chance of difficult oxygenation. This is a MRI picture of a sleep apnea patient. You can appreciate there is a constriction of the airway during sedation of the patient. This is the ASA guidelines for difficult airway. I am not going into detail. Going to the other tools of our intubation, first check the conventional one, our laryngoscopy and intubation. First we pre-oxygenate the patient with 100% oxygen for 3 minutes. After that we take the laryngoscope, we hold it by our left hand. We introduce the laryngoscope by keeping the tip slightly right. After that we make it straight. Thus the tongue is pushed to the left and don't obstruct our view. We introduce the laryngoscope up to vallicular. At the base of the epiglottis, we keep the tip of our laryngoscope, and then from our shoulder we push the laryngoscope handle upward and forward direction. This makes the vocal cord visible. And under full vision, we introduce the endotracheal tube. Just push the endotracheal tube up to the cuff, goes beyond the vocal cords. We take the marking. After that, the cuff is inflated and tube position is checked by auscultation. We auscultate right upper part of the lung, left upper part of the lung, right vessel, left vessel, also epigastric region. Now, all the chest parts should be bilaterally equal on auscultations, and there should be no sound from the epigastric region. If it is not so, if there is more sound in the right side, we have to remove, deflate the cuff first, then remove the tube by few millimeters and check again. And if there is sound only in the epigastric region, remove the whole endotracheal tube and intubate once again. There are many techniques for difficult ventilations and difficult intubations. I have marked dark blue the technique we usually apply in our setup. So coming to individual, the bag mask ventilation is a gold standard for ventilating our patient. We can apply this technique inside the operation theatre, also the outside in the emergency site. During back mask ventilations or during intubation, we usually keep the patient on supine on a hard surface with a 10 centimeter with a pillow below the occiput to keep the patient's head in a sniffing position. Sniffing position is flexion in C5, C6 and extension in C1, C2. It makes the oral axis, the pharyngeal axis and laryngeal axis in a straight line. And this is the way we should hold a mask. These two fingers will hold the mask. This finger will give the chin lift. This finger will give the jaw thrust, and with the whole hand will give the head tilt position. For obese patient, we try to make the manubrium and tragus in a horizontal plane by putting pillows or sheets below the patient's head and back. The back mask ventilation technique is essential. We should use appropriate size of mask, and maybe oral airway or nasal trumpet may be used along with it. Denture should be removed before. We may use water soluble lubricant gel for a good seal, especially if lots of facial hair. This is a difficult airway case of a burn victim. We usually do some minor procedures under inhalation anesthesia with mask ventilation. This is a oral airway. It aids to our ventilation, and this is a nasal airway. If the pharynx is constricted, it prevents this part of the constricted airway, as I have shown before in our MRI picture. This is an intubated stylet named Bougie. We usually, after laryngoscopy, instead of endotracheal tube, we introduce this Bougie inside the trachea up to carina. Then we just railroad the endotracheal tube over it. Advantage is it is a definitive airway, easy to learn, inexpensive, can be used blindly. Disadvantage is expertise still required, not recommended in can ventilate, can intubate scenario. Now laryngeal mask airway, short name LMA. It has now introduced, revolutionized the ventilation in difficult airway scenario. There are different types of LMA. This is a classic type of LMA. This is a pro-seal type of LMA. It is supposed to prevent the aspiration related risk. This is a intubating type of LMA. It helps to intubate along with LMA. This is a short video regarding introductions of LMA. With the right hand we first introduce the LMA. The index fingers pushes the LMA, and with our left hand we also again push the LMA further. In proper position, the tip of the LMA usually blocks the esophagus. After inflating the cuff, usually this part comes out a little bit. And this tip of the LMA usually blocks the esophagus, and it may prevent, acts as a stopper to prevent the aspiration related risk. It prevents the gastric contents from coming out. But it's not a foolproof. Here lies the epiglottis, and the LMA opening lies just in front of the tracheal opening, so patient gets the fresh gas flow. There is also a technique named retrograde intubation. Here in a AVEC patient, we puncture the plecothyroid membrane with thread wire through vocal cords. It may exit through nose or mouth. Then we guide endotracheal tube through vocal cord over that wire. Advantage is it is a definitive airway. There is need for minimal neck movement. It does not require full mouth opening. Disadvantage, it takes time, requires skill, and not recommended in cannot intubate, cannot ventilate patients. So fiber optic intubation is the most versatile intubating tool of our time. we can intubate by fiber optic intubation in a awake patient through oral or nasal route. Preparation of patient is very important in this case. The most important part is explanation of the procedure and win the confidence of the patient. The medications are used like sedatives, we use midazolam. For analgesic, we use tramadol. We take aspiration prophylaxis. Glycopyrrolate we use as anti-secretory agents. Nasal mucosa vasoconstrictors like xylometazoline is used. Tracheal tube is mounted over the fiber optic bronchoscope. Patient may be lies supine or maybe also kept in semi-supine or in sitting position. Anesthesia of airway is done by nebulization, by topical spray and gels, by transtracheal injection or by spray as you go technique. Nerve blocks can be applied. We usually use the topical spray and gels and transtracheal injection. If not adequate, we go for spray as you go technique. So the insertions of fiber optic bronchoscope should be kept straight and the scope usually maneuvered only in 3 planes. The secretion is aspirated along the introduction of the bronchoscope. If there is loss of target, withdraw, identify the structure and re-advance. The targets are epiglottis, vocal cords, tracheal cartilage and carina. These targets are kept in center of view as fiber optic laryngoscope is advanced. Advance to close up the carina, then tracheal tube passed over the fiber optic laryngoscope. The tube position is confirmed and secured, then anesthesia is introduced. Then coming to surgical access of the airway, the most preferred method is cricothyrotomy. This is a life-saving technique, but we should practice this procedure before starting rapid sequence. In this surgical access, there are usually, we think tracheostomy is the method of choice, but in tracheostomy at least 3 minutes is needed. But cricothyrotomy can be performed within 30 seconds. The techniques are, we first extend the head and neck and identify and immobilize the cricothyroid membrane. Then a horizontal stab incision through the skin and cricothyroid membrane is given. And the scalpel is kept in that position. Then caudal and outward traction of the cricoid cartilage is applied by tracheal hook. Then remove the scalpel. Then insert the tube and inflate the cup of one tracheal tube of 6 inner diameter is used. Then ventilate the patients with low pressure sources. Then confirm pulmonary ventilation. Though the technique may sound very simple, the hardest part of doing a cricothyrotomy in a given situation is just picking up the knife. So coming to our plan, in a case of anticipated difficult intubation, we usually go for awake intubating techniques, usually with the help of fiber optic bronchoscope. In a case of unanticipated difficult airway, we go as usual, like plan A, direct laryngoscopy. If failed, then we may go for laryngeal mask airway. If successful, we can do the OT under LMA or may intubate through the LMA with the help of fiber optic bronchoscope. If there is failure of oxygenation with LMA, we may revert back to face masks and oxygenate the patient. We may postpone surgery, awaken the patients and go for awake techniques. If there is still failure of oxygenation, then we may again go for LMA. Still increasing hypoxia, then straight away go to surgical techniques. In case of unanticipated difficult tracheal intubations in a full stomach patients, there is no scope of LMA at first. After failure of intubations, we go to face mask, oxygenate and ventilate techniques. If there is failure, as a last resource, we may try LMA. If there is failure, straight away go to surgical interventions. That's all. Thank you for patient listening.
Thank you, Dr. Suryabrata, for giving a world-class presentation. This is a very excellent presentation you given for the world community. Thank you.